Hey, good morning, everyone. Thank you all for being here. And my name is Jillian Buckley. I'm the study director on this project. And since we're about ready to start, I'll let our chair, Guy Palmer, take it from here.
All right, thank you, Jillian. Well, good day, everyone, in whatever time zone you're in. And I just want to start out by welcoming everyone and sharing the appreciation of the committee for your time this morning. Just about to show up there. Just a little bit of a preamble before we get started. I know the committee's heard this now multiple times, but I think it's important for those of you who are joining us for the first time, is to remind you that this task is being undertaken by this committee of the National Academies of Science, Engineering, and Medicine, with the goal of examining the long-term medical and economic impacts of increasing antimicrobial resistance. This task is being undertaken by this committee, includes commenting on progress against the national strategy of combating antimicrobial resistance, and the full task is described on the study website. I want to note this is an open, on-the-record session. Interested individuals, members of the press have been invited to attend and are certainly welcome. However, this is not a news conference, and we will not be entertaining questions from the floor. Reporters who would like to speak with committee members are requested to touch base with our study director, Jillian Buckley, and her information, her contact information is on the study website. This is an information gathering session at this point. That is, the committee is in the process of assembling materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. As a consequence, I ask that everyone be extremely mindful of the fact that this committee has made no conclusions, and it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including committee members, should not be interpreted as positions of the committee or of the National Academies. Committee members may ask probing questions in these information gathering questions that are not indicative of their personal or professional views. The committee will then deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it goes through rigorous review by experts that are anonymous to the committee, and the committee must then respond to that review with appropriate revisions that adequately satisfy the National Academy's Report Review Committee and the National Academy of Sciences president before it is considered an official National Academies report. So we have a full agenda this morning and want to get started on that. For panelists, as you've, committee members, as you've noted, we have really limited time for questions. We'll try to get to all of those, but if you'll put them in the chat directed to everyone, that way the speakers can see them as well. And if we don't get to them in real time, they'll be aware of those questions and hopefully can answer those and provide some information to us following the, either in the chat directly or following the session today. So with that, I think let's proceed and get started. And Jillian, I will turn it to you to introduce our first speaker.
Happy to. So our first speaker is from the World Health Organization, Division of Antimicrobial Resistance, Carmen Pessoa da Silva, talking about the Global Antibiotic Resistance Surveillance System. Thank you, Dr. Pessoa da Silva.
Thank you very much, Jillian, for the nice introductory words, and thank you, the organizers, for giving us the opportunity to share with this committee some of our work and our experience. So I will try now to share my presentation. Let's see, I hope that now you should have my slides.
Now we do, yes.
Yeah, good. So this presentation is about the Global Antimicrobial Resistance and Use Surveillance System. And what I would like to briefly go through with you is about the GLASS development, the steps for the development, the summary results, particularly from the last report, and then reflect on some challenges, as I think that this committee could help in terms of bringing new ideas and solutions. So then, in terms of the start of GLASS, it was launched in 2015, just after the Global Action Plan on Antimicrobial Resistance was adopted by member states. And when they adopted this Global Action Plan, they also requested the WHO to establish a global system for monitoring the situation worldwide. So GLASS is actually the first global system to incorporate official national data from surveillance on AMR. And I highlight the aspect of being official national data because it's really the data that the governments recognize as themselves and can then take action and then develop policies. So this system, it provides standardized approach for the collection, analysis, and sharing of AMR, AMC, and AMU data. It also brings One Health model and tries to generate information to inform the burden of AMR. The initial focus of GLASS was on AMR in bacterial infections in humans. But we do understand that several other components, pieces of information are needed in order to really understand what is happening in terms of AMR. The additional pieces have been indeed incorporated into GLASS since the launch in 2015. So if we walk through the journey of development of GLASS, the initial step was the first global report on AMR surveillance that was issued in 2014. So GLASS did not exist. This report was to do a landscape analysis of what types of surveillance were being used by countries. And it informed the development of the global standards that was launched in 2015. Then 2016, we started the country enrollment. And since 2017, we started annual data calls with resulting in annual reports. So far we have 3 reports just issued. And 2019 was marked by the incorporation of new components. I will go through them in a minute. But now, 2020, so 5 years after the launch of GLASS, and also as agreed with our member states, we would develop GLASS by cycles of 5 years. And every 5 years, we should be coming back to member states in terms of revising and discussing what would be the next steps. So in this regards then, we are now conducting online technical discussions that just started in October and will go until February next year with all countries, all WHO member states, to discuss the system, to discuss the next steps and what could be the direction. And these technical consultations will inform ultimately the third high-level technical consultation that will happen in Stockholm. Hopefully, if COVID permits, it is planned for April next year. So it will be based on this revision that will then define the next 5-year cycle of GLASS. But then now to give you just a quick overview of the current environment of GLASS, I mentioned to you that the first component was antimicrobial resistance in bacterial infections. That we have incorporated antimicrobial consumption. Also, for information, this year is the first year where we are running a data on antimicrobial consumption, so national data. And we have also added component 2 years ago on the early reporting of emerging AMR, so this is GLASS here, to try to capture as early as possible news on novel types of pathogens, of resident pathogens, and this has been very much used by countries basically as a platform to better understand how to investigate these events and how to mitigate them. Now, I mentioned to you new components that are being incorporated to GLASS. So if you consider the mainstream in terms of routine data surveillance being the routinely collected information on both AMR and antimicrobial consumption, for other streams, we have focused surveillance. I mentioned the emerging pathogens, but we have also a focused component on Neisseria gonorrhea, multi-resident Neisseria gonorrhea. As you may know, it's becoming an almost untreatable infection. So GLASS, the multi-GLASS already includes Neisseria gonorrhea among the pathogens for surveillance. But the enhanced surveillance for gonorrhea is looking into more information from patients that acquire this disease and looking also at risk factors in the population. The other focused surveillance component is the component on surveillance of invasive Candida species. And the rationale for the inclusion of this component is the emergence of a very much resident species of Candida, for instance, Candida auris causing outbreaks and associated with high morbidity and mortality. And therefore, we yet do really not know much about the magnitude of the problem. So we are now just piloting the protocol and that has been published. And we hope that towards next year, we'll be able to fully incorporate into the GLASS environment. Then coming to surveys and studies. The first one is about a model for One Health surveillance of AMR. And this is about looking at this phase we start. It is about looking at one AMR indicator, the extended spectrum beta-lactamases, E. coli. And so the ESBL E. coli across human sector, across the environment and food animals. So several countries have already implemented this One Health, and based on the experience of these initial countries, we are just about to publish the revised protocol for really fostering the application of this model in several countries. The second type of survey we have already started is the point prevalence surveys to assess the use of antibiotics in hospitals. So far, we have piloted this point prevalence survey in 10 African hospitals, and the protocol, the first version of the protocol has been published, but based on this pilot phase, we will also be revising this protocol. And last but not least, and extremely important, is to have a sense of the impact of AMR on human health. In this regard, this year, we have published a protocol for the estimation of a tree due to antimicrobial resistance in bloodstream infections. This protocol is also starting to be applied. Already few countries participating in GLASS have expressed the interest in applying the protocol. And we are also very grateful for partners such as Wellcome Trust colleagues that are also now supporting the application of this protocol in some countries. So if we think about where we are, I think this map shows how quickly in 4 years we had the let's say the participation of countries in the GLASS system. So as of today, we have 100 countries participating in GLAS. It is true, though, that it is really the very beginning. And while some of the countries that are participating had already mature surveillance systems and are providing representative data, particularly high-income countries, we have to acknowledge that particularly the low and middle-income countries, they are really starting their national system. So the participation in GLAS has, let's say, has fostered the development of national systems in these countries, but they are themselves at the very beginning. But I think that it's, I mentioned to you that in 2014, we had a first report to have a landscape analysis of what was being done in terms of AMR surveillance. And if you think about the impact of GLAS in fostering the development of surveillance systems, this slide, I think it tells by itself. If you have the first picture on the left side is the map of African countries that in green, you can see the African countries that could provide at least one or two indicators on AMR by the year of 2013 that was used for the 2014 report on AMR surveillance. So the blank areas imply countries that did not have any information on AMR surveillance to provide, not even, let's say, structures for AMR surveillance in the country. Then, as of today, you can see the contrast in your right side, the countries in pink and in blue, that are the countries participating nowadays in GLAS. So it is true that most of these countries are really at the very beginning and are still being capable of providing limited amount of data. But it is fantastic that they are developing the infrastructure for AMR surveillance. Now, at this point, I would like to share with you some of the data that is collected by GLAS and the results. So in the end of the day, what data does GLAS collect? It is not only about AMR data, that indeed we do, up to the moment, we look at 8 priority human pathogens in 4 clinical specimens. And we also try to get information from overall number of patients tested for the specific specimen and the patient information regarding age, gender, and infection origin. But in addition to the AMR data, we also follow on annual basis the status of national AMR surveillance system. So we do ask countries about the elements of the surveillance system. So how many surveillance sites they have established. We ask details about the National Reference Lab and also the National Coordinating Center so that we can follow the level of development in each country. And this is a concern particularly for the low and middle-income countries in terms of how they are developing their systems. So if we just have a quick look at the type of data that was provided in the last report. The last report was published in May. Yeah? It reflects the data call run last year in 2019, and therefore it's the information of the status, the actual information in 2019, but the AMR rates is about the previous year. So by that time, we had 82 countries enrolled in GLAS, but only 78 countries could provide any information. And I call attention that 12 countries could provide only information on the status of their national AMR surveillance system, and that is okay. because it really shows the efforts these countries are doing to structure their systems before they start sharing data. So in the end, we had AMR rates from 66 countries, because one country just provides rates only. And the distribution of countries, one might think that it's basically about the high-income countries participating less, but actually this is not true. Here, this graph shows the distribution by level of economic status, from low-income countries up to high-income countries. And it's about only 1/3 of countries are high-income countries, being the rest composed of low and middle-income countries. And it shows a progress in terms of their participation for both, from both the least developed countries to the most well-resourced countries. I mentioned to you that we do collect information on some indicators of the structure of the surveillance system. I will not go through all indicators in these presentations. All information is available online, but this slide is only to provide an example of the type of information that we monitor. So for instance, here, the 77 countries that provided information on status, we looked at some aspects in their national reference labs. For instance, whether they participate in an EQA, and in the end of the day, they also disclose when their limitations. And as you can see, the red ones imply the ones that do not yet participate in an EQA. And in fact, very frequently, the ones that do not yet participate in EQA are the ones not yet reporting AMR rates as well. And also we ask things like what are the international standards that are used. We do recommend that either UCAST or CLSI standards used for the identification of AMR. And we can see that it's basically the vast majority are really using one of these two standards or both. Now, looking at the, let's say, the evolution, the progress in reporting, I think that in this table, you can see, according to the year of the data call, the number of countries that could report AMR data, so growing number of countries, and the total number of patients with suspected infection. So this refers to count the patients with laboratory confirmed infections. So it's quite amazing to see from 500,000 to more than 2 million patients enrolled over this period. And looking specifically in the results from the last report, so this refers to the more than 2 million patient infections, you can see in this table the distribution according to the site of infection, the number of infections per site. As you can see, urinary tract infection and bloodstream infections have so far been the most frequently reported. Also the distribution according to the etiology in each of the sites of infections. Here, I think that one important thing that we need to also look is that although you've seen that they have reported more than 2 million and more than 300,000 patient infections, in the end, there is a lower number of infections that we could do the analysis. You can see the last column counts only just above 2 million patients because let's say there is a proportion of the infections that although they identified the etiology, the susceptibility testing was not done. So there is also this kind of incomplete information that we have to deal with. In any case, it's an amazing, let's say, collection of information, and it includes both community and hospital infection. Yet, at least so far, we can see that most countries are not reporting the breakdown between community and hospital infection. So we have unknown as being the main, let's say, category of infections. But we are really fostering countries to try to discriminate because the profile is absolutely different. Now, you've seen, I've heard the previous presentations yesterday, and I remember my colleague, Dr. Anand Balachandran, who mentioned the new Sustainable Developmental Goal AMR indicator. And this indicator is about the proportion of bloodstream infection among patients due to two types of AMR, MRSA and Escherichia coli resistant to third generation cephalosporins. So these two, the main source for the SDG indicator is GLASS. And we tried already to do some preliminary analysis of where we are regarding this indicator based on our database. And we found some interesting initial information that I will share in this slide. So this slide is looking at this SDG indicator for both two types of AMR, and we try to make a comparison between the rates observed in high-income counties and the rates observed in low and middle-income counties. And interestingly, for both indicators, the rates for low and middle-income counties were found to be significantly higher than in high-income counties. Now, I think that we needed to take this information with caution because we need to understand the reasons for this finding. It can be because of biases in the selection of patients that are eventually tested in low and middle-income countries, given the difficulties to access tests free of charge in many low and lower middle-income countries. Nevertheless, these are just hypotheses that we do need to verify. This finding is from the 3 years of data, but yet it requires really further investigation. Now, looking more specifically, I will now just share a few ranges of rates for blood infections. As I mentioned, all detailed information is available on the website, including information per country. For the sake of the time, I just restrict myself to some rates in bloodstream infection. So I think here in this slide is about bloodstream infections due to Klebsiella pneumoniae. And what we see is that for carbapenems, fluoroquinolones, and third-generation cephalosporins, the rates, so the median is really observed, it's really high for all three antibiotics, about 18 for carbapenems, 18%, about just above 40% for fluoroquinolones, and for third-generation cephalosporins, really almost hitting 60%. The variation, as you can see, the dots, the red dots represents each dot is a country, so the variation is quite wide, and therefore we should again take this with caution and try to understand the biases in specific countries that may have influenced these high rates. Along the same lines, for bloodstream infection in Acinetobacter, which is really emerging pathogen, of very high concern. We can see the high rates of resistance against aminoglycosides and also carbapenems. And again, here we see a wide variation of rates. Therefore, we should look, especially in the individual countries, look for biases that might have influenced, skewed these results. And now, just this slide, I would just like to call attention on the second bullet point about the response to ciprofloxacin in urinary tract infections. You have seen in previous slides that this has been the vast majority of infections reported to GLAS are urinary tract infections. Every year, more than 1 million cases reported. And what we observed is that the response to ciprofloxacin, which is very common antibiotic used for treatment, is really very high against both E. coli and Klebsiella pneumoniae. And the number of countries reporting between 33 and 34. Now, I think that there are several limitations in this data. I really, again, call attention, emphasize that we are just at the beginning. GLAS has just started in these countries. And in many countries, we still are facing major barriers to really have reliable and representative information from the country. And this pyramid is to illustrate some of major challenges. Think about the population that is the bottom of and then up to having infections and channeling results to GLAS. Well, the first step here, once any patient needs healthcare, the patient needs to have access to healthcare. And this is not always the case in many countries. So there is a need for universal health coverage. And there is a link between combating AMR and also assisting, helping with the universal health coverage because there are cost impacts, but vice versa. Having universal health coverage also will facilitate the access to healthcare and eventually testing and knowing what is going on in terms of etiology. But once the patient has an infection suspected, interfere negatively on the results. I'll just stop here at the quality of microbiological tests that are performed that very frequently are not reliable. So, and this is very expensive for many countries. So the need for lab strengthening is a reality in many, if not most, low and lower middle income countries. And even we can succeed all these steps, yet the culture of surveillance, providing data that is recorded, analyzed, and complete and reported in a timely manner is still not there. So we would still need to work particularly on the representativeness of data that is submitted to GLAS. So in conclusion, I think that there are few, let's say, few messages from this I'd like to share. The very first one is that GLAS relies on continued data sharing as well as global collaboration, because the tasks to assist countries in developing their capacities is huge, and we do need in these countries and implementation of AMR surveillance. The second point is that it is true that countries face challenges to building their surveillance systems, and not only WHO, but also partners can play a key role in assisting these countries. But here, it is really important that we try to converge the efforts, to converge the messages, sometimes just having several partners, but if each partner is speaking a different language, it may not help countries. So we do need conversion, and we do hope that GLASS can offer this platform for conversion of messages. I talked a lot about the data limitations. While we acknowledge these limitations, I think that we should understand these limitations and use them to improve the system in each country. So it could not be used as an argument not to do surveillance, but rather to improve it. And last but not least, I think that the sense of country full ownership is really paramount. And it's not only the ownership of the data. Of course, they are the ones that, even if they wish to withdraw their data, they can do it in time. But I mean by country that they understand their data and they act upon this data. And finally, I think that the most important message I'd like to leave with all of you is that the global system, GLASS, is really just the initial steps. And we do hope that the system would remain as a legacy for the future generations, and that in the coming years, we could really have a solid, robust global system that can provide, let's say, a representative picture of the problem worldwide. So with that, I thank you for your attention. You can get more detailed information on GLASS on our website, but also information from other WHO AMR surveillance initiatives that I link with you in this, the links in this slide. So thank you very much.
Thank you.
Thank you. Oh, go ahead, Joanne.
No, you go, please, Guy. Go ahead.
I was going to say thank you very much, Carmen. That's really critical information, obviously, for the role of GLASS for all of the countries and globally, and as well as the global distribution. There's a series of questions that our committee members have posed. They're in the chat, and I am confident you're very busy, but if you have time to address those in the chat, that would be fantastic. If not, we can get those questions to you and you could respond later by email if that's possible. Or if you don't have time for that, we could find a way to connect with you because I think some of those questions are really critical for the committee's full understanding. So thank you very much. And we may have, if you're available later in the session today, we may have time to address some of those as well. So thank you.
Yes, I will be.
Okay.
I could not hear your question. I think that the system was disconnected for a while.
Okay. Yeah, thank you. I think to stay on schedule, we'll move ahead with Tim Jenks for shaping strategies for prevention and response to antibiotic resistance from the Wellcome Trust. Good afternoon, Tim.
Hello, good morning, and good afternoon, everyone. Thank you very much to the organizers for inviting me. And please bear with me while I move to my presentation. Make sure that's all ready to go. Very good. So today, what I want to talk about is Wellcome's strategic views as relates to drug-resistant infections and the AMR agenda. And first, what I want to start with is Wellcome Trust's strategy as a whole. We recently launched a new strategy across the organization. And then within that strategy, we've revised our views and approaches to AMR and drug-resistant infections. So I hope that all this information will prove relevant to the discussions that you're having here. So with respect to Wellcome's new vision and strategy, we as an organization are supporting science to solve urgent health challenges facing everyone. Though we are based in the UK, we are globally oriented in the issues that we wish to address and the areas of action that we pursue. So for our strategies, we are focusing on 3 worldwide health challenges in a programmatic approach. And we're doing this in a way to draw on our expertise across science and innovation, culture and society, and wanting to be very clearly ambitious in our own goals and the impact that Wellcome Trust can have. Of course, we will continue with a broad program of discovery research. And this is something that should be done across a wide range of disciplines. And discovery research is an area that can't be overly tactical in what we want to do. We want to make sure that discovery research continues to be an unfettered space so that ideas can be unshackled to support the challenge areas that we want to achieve success. And lastly, and very importantly, though, we want to make sure that diversity and inclusion and the research culture are improved in everything that happens and everything that we do. So first, to focus on the 3 urgent health challenges, as well as how those are underpinned with discovery research. I'm going to skip through this part very quickly, but I think it's important you see the broad context. And of course, first and most important to me, but not first amongst everything at Wellcome, is infectious diseases. And what we intend to address are those escalating infectious diseases so that they can become under control in the communities most affected. And really that phrase is supposed to indicate an approach that allows us to have a degree of focus so that we're not trying to pursue all infectious disease challenges that exist throughout the world and for all communities. But in fact, those where there is a significant or rapid change in the status of prevalence of infectious disease, and certainly want to focus our efforts to improve the situation for those who are worst off as a result of it. We also are focusing on the impact of climate change on human health. We want to make sure that as the climate increases in heat, that it does not harm health in the communities most affected, or at least we can reduce the impact of health overall. And the third challenge area, I've managed to skip over mental health. And here we want to be clear that no one is held back by mental health problems. There will be a sub-focus on young people and the impact of mental health in reducing their opportunities in communities overall. Now, we do expect that over time, as we move forward in these focus areas, that there will be a cross-fertilization between them, because we know that there are linkages and drivers in all of them that actually confound the issues that mean that human health is degraded. But of course, as I said before, this is all built on a strong base of supporting discovery research. We want to make sure there's significant shifts in understanding so that the new ideas and the new understanding can really usher in new ways to improve human health. Now, why are we wanting to do this? So we looked at a set of factors to identify how to focus in particular areas. And we wanted to make sure there were urgent and very large scale threats to human health throughout the world. And of course, very importantly, these have to be things that Wellcome Trust itself can make a difference. A number of things that are hugely important in the world that others can identify, but Wellcome Trust might not be the right organization to do that. So you know, part of the selection here is very much informed by what is it that our organization is most suitable to take on. And of course, we want to make sure that we harness what differentiates Wellcome from other organizations. I will jump ahead here and go to the area that's the topic of the day. And Wellcome Trust has long prioritized the issue of AMR as one to be addressed, and it will continue to be a very high priority in what we do within the infectious disease challenge area. And what we're doing is building on what's up till now been called the Drug-Resistant Infections Priority Program. And we're moving into a period internally described as bridging, where we're going to transition the activities of the priority program into the infectious diseases challenge area so that it's fully integrated into a bigger approach of looking at the challenges related to infectious diseases. Now, this is where we have a sub-strategy that is focused on drug-resistant infections and the AMR agenda. And we have a vision that the world should be one where nobody is endangered by drug-resistant infections. While this is a hugely ambitious vision to pursue, it's one that actually is realistically achievable. Now, I want to be very clear, we're not talking about trying to control or wipe out antimicrobial resistance. AMR is a biological phenomenon that will never go away. However, the impact of AMR on human health is something that we can mitigate against, and we should seek that ideal goal that drug-resistant infections should be absolutely managed and controlled. Of course, right now, AMR is posing a very significant threat across the world, and it requires urgent action. What we did is we developed a strategy of action looking in a 5-year window, but it's actually anchored in a 20+ year perspective. So we thought about, well, what needs to happen on a very long period of time? You know, the fact is that everyone's awareness of AMR as a threat, it's been around for more than 40 years, and we've had very little progress overall in addressing this as an issue. And we know that it's going to take decades for everything to get into place before that control can truly happen. So we looked at the long-term perspective and worked back to have this 5-year window. And within that, we designed a 2-year bridging proposal to integrate the integrate the program into the infections challenge area. So something that's very important is thinking about, well, really, where do we sit in the global AMR agenda? And I'm not going to go through everything that is presented on this slide, but what we looked at were the different areas of action as had been set out during the UN Interagency Coordination Group's analysis of the AMR agenda. And there were a number of places that do require urgent action and action over decadal periods. Wellcome can't do it all, and we certainly shouldn't try to do it all, but we certainly do have to be fully aware of all of these areas and understand where we act and how that fits into the bigger picture. But we've decided that we can focus on a subset of this overall agenda. And in that, we are focusing on national action, innovations, surveillance, and human consumption of antimicrobials. And a quick word on really how we go about doing this, and describe it in 3 different approaches of support, facilitate, and advocating. And support is funding and investing in projects that will deliver relevant results. And facilitation is us working in partnership to enable others to deliver. And lastly, advocacy, and this is something that's very different for Wellcome Trust, though maybe many of you have become aware in the last couple of years that we are stepping forward as a very active advocate for the things that we think matter. And we want to use evidence to influence action. So I want to touch on 2 high-level goals that we're focusing on in the immediate future. The first one is to advance a sustainable pipeline of antibiotics to protect global public health. And we've looked across the entire life cycle of R&D for antibiotics and thought about where we could act and in what ways we can act. And I'm not going to go through in detail what is set out in the slide, but just to say that we think it's very important that the early stage R&D is a place that we continue to invest in the research activities. And we're looking to mobilize action further down in the pipeline, and particularly as we move into the space where antibiotics move into the healthcare systems. And there's a tremendous barrier at that downstream point where we will be looking to see change, and we will advocate for change in the uptake and use of antibiotics, and we're looking to identify ways to bring forward relevant information that will support interventions. Our second goal is to foster the mobilization of government-led action on AMR. And of course, at the heart of this is evidence, and that evidence is something that should inform understanding and action in relationship to the financing of everything that needs to be done. The fact is, it's a simple truth that money is a necessary ingredient in everything that happens here, and one that was in very short supply even before the COVID pandemic, and it's going to be increasingly challenging as the global economy is in a particularly bad state. But nonetheless, prioritization needs to happen, and the financing of these things will be informed on the basis of relevant evidence and information to support priorities in a national agenda. Alongside that, very importantly, is coordination. There needs to be coordination at all levels of action in the AMR agenda. That's starting at the local, regional, national, and right up to the international and global activity. So coordination is a very important ingredient that we hope to foster and mobilize so that country-led and country-owned action is best able to happen. So within that, we want to make sure that there's sustained cross-sector support and funding around National Action Plan implementation, and of course, evidence-based prioritization of AMR National Action Plans that are based on data and research. Around that, we want to support research that develops interventions and policies that enable AMR National Action Plans to be implemented, and of course, strengthening partnerships and networks to build capability and capacity so that National Action Plans can be implemented and truly action-oriented and not simply paper exercises. So all of that's very high level. And what we've done is actually worked our way down to better inform, well, what are the real actions that we want to see happen? And we frame this using theory of change approaches and define 3 outcome areas that we want our to be able to achieve through actions that we would do. And the 3 outcome areas are: new antibiotics are developed, available, accessible, and affordable; appropriate evidence-based use of antibiotics and the optimum use of antibiotics; and alongside that, the implementation and robust country-specific, country-led, country-owned national action plans. I'm going to quickly walk through some of these areas, but it's just a hop, skip, and a jump, and I do apologize for moving quickly. But with the first outcome for new therapeutics, we think the development of new therapeutics is crucial to offset the effects of AMR. However, antibiotic development itself has been hindered by some fundamental economic challenges, and those that relate to the failed business case around antibiotics. So what we are going to prioritize, in addition to the support for funding R&D in this space, is policy and advocacy. And we want to see that there's resource mobilization to support the later stage development, and particularly the commercialization, and also supporting the supply and access to antibiotics, as well as the uptake of diagnostics that are relevant to using antibiotics. We have a structured approach here to understand, well, how might we wish to see achievement of those outcomes overall? And this is really where we have identified the areas for action that we want to see happening. So I won't go through each of the details. I assume the slides will be available, but we've broken it down roughly into areas of capacity and capabilities, commercialization, as well as evidence. And we will pursue a set of activities, actions, funding research, and working with partners to bring forward the information and results that can create the outputs that are relevant toward the outcomes that I've described. Of course, very importantly, the 2 high-profile areas that we've been working in, one is the co-funding partnership of the accelerator CARB-X, which was set up by BARDA in the US, but is now co-funded by the UK government, German government, and Bill and Melinda Gates Foundations alongside Wellcome. And that supports the early stage product development for products related to AMR. Recently was announced an industry-led funding body to support later stage R&D for antibiotics, antibiotics only. And this is the AMR Action Fund. And Wellcome has been working alongside industry and a working group to inform how the Action Fund could best address global public health needs. And we're considering investing in the fund to help drive that forward. But what's important here to us is thinking about, well, really, what will the outputs be from these sorts of activities? How can they be moved forward so that at the end of the day, we can see the achievement of the important goals. And that is to have products, tools, and interventions that improve public health. So I've just spoken briefly about the AMR Action Fund as an example activity where we're working, but there are other ideas of what we need to do, and very clearly the broken economic market is an issue. And so we will be looking at issues that can change the reimbursement space around antibiotics. And one of the big issues there is around the evidence on that space. So what we will be doing is advancing our advocacy activity around this, and we want to support and promote development of new reimbursement models in the key markets that drive the commercialization of antibiotics. We are likely to continue a project that we support at Duke Margolis, as well as at the Office of Health Economics here in the UK, that inform the feasibility of pull incentive solutions. And of course, these are focused on the US and UK markets, but the evidence and information around these can be broadly applied to other high-income country markets. And of course, we are looking to expand on this work to develop a more global perspective so that the evidence can better inform the marketplaces in other parts of the world. Our second outcome space is the appropriate evidence-based use of antibiotics. Of course, we all recognize that access to antibiotics is a significant issue and is often the greatest concern in low and middle income countries, so much far greater than the issues of innovation and the commercialization of innovative products. Of course, alongside that, antimicrobial treatments are often misused, which increases resistance, and the suboptimal usage of antimicrobials is a driver of AMR as well. So what we plan to prioritize is the generation and sharing of data on optimal use, and also want to develop context-specific interventions that support the optimal use of antibiotics. And we think this is a significant gap in the space, and the context-specific issue is a particularly important one because much of the work that is done is really for high-income healthcare settings. And lastly, implementation, uptake, and capabilities, particularly around diagnostics, that support optimized use. So that is a slightly complicated way of looking at the situation in the healthcare setting and come up with a better set of tools so that innovative tools, products, and approaches actually are implemented into healthcare practice. As before, we have a much more detailed theory of change that we developed around this so that we could better understand those activities that can support those outcomes and deliver outputs that are relevant to what is important. And without going into too much detail, it won't be any surprise here that generating additional data is a key thing. And much of what Carmen described in relation to glass and glass activities kind of maps very tidily into this. You know, the fact is that it's not simply a case of looking at antimicrobial resistance in isolation, but it's also use and understanding supply and demand enablers in that space. An example activity that we'll be launching is something that is an idea of Professor Mike Charlin's, and we'll be working in partnership around this. It's AMR, Data to Inform Local Action, DILA for short. And this is to develop a new set of data that better informs how antibiotic usage can be optimized. And this is a project that will be performed in a number of countries and will be focused on low and middle income country setting so that there can be a better evidence-informed set of tools to be made available to countries that are looking to engage in stewardship improvement. Our third outcome is around the implementation of those national action plans. And while we all recognize that most countries in the world have a national action plan that has been listed with the WHO, the reality is the plan has not automatically translated into action. And this is particularly so in low and middle income country settings where there's a lack of available resources to do any implementation and a shortage of political will, all of which means that there's no real progress on the ground. So what we plan to do is really undertake something of an experiment within Wellcome. We need to understand really how can we engage at a country level in order to move this agenda along. We are not an international organization like WHO. We don't intend to expand our footprint in that way. But what we do need to do is understand what are those things that we can do that can serve as catalytic information or set examples or case studies that others might follow. And again, there is the theory of change around this. And what we'll be looking at is taking an in-depth analysis to understand the barriers against national action plan intervention and identify tools and exemplars that enable viable national action plan policy and practice to be implemented. Of course, we want to see there's coordinated action within countries and see what it can take to achieve better concerted mobilization there. All of this will be built in partnerships and networks, and we're looking to facilitate more of the partnerships and networks to be available to countries. And lastly, certainly not leastly, a big theme is data needs to be gathered and made available, shared in all cases. An example around this, and this is a bit of a departure for us, I think very exciting, is we wish to launch a virtual AMR policy think tank. And this policy think tank is one that will generate actionable evidence-informed policy. And it's one that can support capacity building that enables policy learning throughout the world. This is an idea that's being developed by partners at the University of York, at the Global Strategy Lab. And this think tank will work in a way that coordinates global expertise of AMR researchers to bring together the best ideas. It will be done in a structured way that topics will be driven with review and evidence and policy gaps, and will provide a rapid response function for urgent requests that countries might make so that they can gain access to policy thinking and evidence on an ad hoc as needed basis. And again, for us, it's very important that there should be strong engagement with low and middle income countries in this space. So in summary, Wellcome's new strategy includes a major focus on infectious diseases, and this challenge area is going to concentrate on finding solutions for those diseases posing an escalating threat. AMR is an increasing global health burden requiring continued urgent action. And we're committed to continue working on solutions for protecting people from drug-resistant infections. And lastly, I just want to make a plug. As part of the work that we've done to inform our thinking, we commissioned a landscape analysis on the progress with global action and the global agenda for AMR. And this led to us producing a report that we're going to launch next week. And so the global response to AMR report will be available, I think, starting November 16th, but the launch event itself will be on the 18th. And there's quite a lot of information in that we gained in the course of that activity. And we think it's be very relevant to many actors in this space. Thank you very much.
Thank you, Tim. That's fantastic. We're probably actually going to go to a break here in the next minute, but there's a couple questions that were put in the chat that if we could get you to address either in the chat or in another format. I know you're very busy. What type of evidence will you be looking for in optimized use? And the other is something we're very interested in. Can you elaborate on the types of pull incentives that you're considering? And a third one, just to fill up your day completely, that I would toss in is, I know the trust thinks very carefully about where their investments are. This can be a crowded space with a lot of different agencies, from international to national to different foundations. Where do you see the strengths in that or the concerns in that? So I'm going to lay 3 questions on you, and then I'm going to take a break. So it's a little unfair, but.
All right, no, that's perfectly fine. So the first 2 are in themselves pretty big, and ones that probably be best if we follow up in writing.
Okay.
And the first one I'll try and take on in the chat, as long as it's there in the chat for me to see.
Yeah, I think you can see it. It's what type of evidence will you be looking for in optimized use? Is that the question? Yeah. And the others, yeah, if you can respond to them, that's great. If not, we can follow up individually with you, just depending on your schedule. Okay, I think we're going to take a quick break here, 10-minute break, and we will reconvene at 1/4 after.
Super. Excellent. Well, it looks like it's about time for us to get started again.
Yep, super. Slight delay there. Yes, happy to invite our next presenters from the Fleming Fund and their support for AMR surveillance, and it's Tom Pilcher and Claire Gordon. So I will turn it over to you two.
I'll share my screen to kick off, and then we'll get going with the presentation. So, as you mentioned, my name is Tom Pilcher. I am the head of country coordination of the Fleming Fund. I work in the UK's Department of Health and Social Care. And I'll hand over to Claire Gordon to introduce herself just while I get the presentation up and running.
Thanks, Tom. So my name's Claire Gordon. I am a clinical microbiologist and infectious diseases physician. I work for Mott MacDonald, and we're the management agent for the Fleming Fund. So we oversee the country grants, regional grants, and fellowship program for the fund.
Great, thank you, Claire. Can I just check that you can see the presentation?
Yes, we can see it. Yes.
Yep.
Fabulous. I'll take that as yes. So firstly, thank you very much for this opportunity to present and introduce the Fleming Fund to you and provide you an update on the progress that's been made over the last 4 years. In terms of what we do, we're very focused on the supporting lower and middle income countries across Asia and Africa in terms of strengthening AMR surveillance and increasing the quantity and quality of data, AMR data, AMU and AMC data. We're not a research fund. I think it's really important to make that clear at the beginning. Of course, much of our outputs will be extremely valuable for researchers globally. We enable countries to improve the collection and use of antimicrobial resistance data because, and that's the focus of our fund, because we see that as absolutely critical. You may be familiar with Lord Jim O'Neill's AMR review, which back in 2016 identified 7 main interventions to help address the escalating threat of antimicrobial resistance. One of those was the critical need for more data. You've heard a lot about that today, obviously from Carmen and Tim already, but we see data as absolutely crucial, not just in terms of helping us to understand the nature of the threat from AMR, but to help us obviously develop interventions, increase awareness, and also help to kind of leverage investment in tackling AMR also, as well as informing national health policies. Here's a map of where we work currently. Our efforts are focused in 22 countries across Southern Africa, West Africa, Southeast Asia, and South Asia specifically. It's a range of countries, from quite small countries such as Bhutan and Timor-Leste to quite large countries such as Nigeria and Pakistan. It's quite a big scope, quite a big geographical spread, and quite an ambitious program. And this is managed via our management agent, which is Mott MacDonald. They manage the program via 4 regional centres in Uganda, Ghana, India, and Thailand. We work very closely with and building national partnerships with each of those countries that you see on the map there from the outset. This is the way we work in terms of the program principles. Really important to note that we are a One Health program. So we don't just support human health laboratories, but we also support animal health and to a lesser extent environmental health. And we work very closely with AMR coordinating committees, which are kind of the AMR platforms in each country. We are very closely aligned to national action plans and the global action plan, and we position ourselves as supporting countries in the implementation of the surveillance aspects of their own national action plans. It's probably worth noting that we have key grants with Multilaps, WHO, OIE and FAO, and much of that support has gone into supporting the development of national action plans. And we also support the kind of governance arrangements for surveillance in countries as part of our country grant programme as well. We align not just obviously to the Global Action Plan on AMR, but also to other donors as well. So we invest quite heavily when we are engaging in country and developing our position activities to identify the other actors in the space and make sure to align our investments carefully with those in mind as well to optimize our investments. I mentioned before that country ownership is absolutely critical principle for the Fleming Fund. We're supporting national public health systems. We see that as crucial for the long-term sustainability of our investments and the overall effectiveness of those. And so we invest, as I mentioned before, quite heavily in building relationships from the outset. This slide sets out very briefly kind of what we do and our overall objectives. As you mentioned before, very focused on collecting, sharing and using data on drug resistance. We see that as sort of critical to enabling clinicians and agricultural sectors to optimize the use of antibiotics, while also helping governments to build appropriate policies and target investment to where it's needed. As I mentioned before, we are supporting national AMR governance. We are building AMR workforce capacity. A good example of that is our fellowship scheme. And much of our investment is focused on building laboratory capacity. Carmen Pessoa earlier today highlighted the real gap in laboratory capacity, and we recognise the importance of GLASS. It's a real objective of our fund that we support getting data into GLASS, and building laboratory capacity is actually a crucial part of that. From then, once data is available, we expect to be able to support improvement in awareness and understanding of AMR. This sets out the wide range of our investments. The investments in blue are kind of the core of our fund, about 180 million, if you like, which is the fellowship scheme, the country grant and the regional grants, which Claire will go on to describe in just a couple of slides. The World Health Organization, FAO and OIE are absolutely critical partners for us, and we work very closely with them in supporting the rolling out of protocols, for example. So our interventions are informed by the protocols and guidance from those organizations, for example. And as I mentioned before, we're very focused on supporting improvements in the use of data to go into GLASS, for example. And Claire will give a little bit more detail on that. But we're also interested in other types of data. So, for example, we have a grant with the University of Oxford and IHME in the University of Washington to support an analysis of the burden of AMR, which is due to report next year. And we're also supporting a number of economists globally as well to do more analysis of the economic impact of AMR. I'll hand over now to Claire to give you a little bit more detail about the core of our fund, which focused on the country grants, fellowships and regional grants.
Thanks, Tom. So to establish a country grant, what we do is we visit the country, we review the National Action Plan and associated documents, meet with the AMRCC if it is in existence, and other stakeholders, and develop a country-specific request for proposals. That's then put to open tender, and organisations and consortium are invited to apply to implement the grant in a particular country. So the RFP will contain varying levels of support depending on the country context, but it will support governance, coordination, as well as the development of technical capacity in the relevant sectors. So it's a One Health programme. We support surveillance across animal health, to some degree in the environment, and obviously in human health surveillance. And it's all with the aim of helping the AMRCC or AMR Steering Committee or whatever form that takes, implement the surveillance component of their National Action Plan. And then that program in a country is supported by a fellowship scheme, which equips a cross-sectoral cadre with more advanced technical skills and develops their leadership potential. And then we have a parallel regional grant stream, which has a number of programs, but also includes programs to develop more standardized approaches for training, for EQA, and standardized surveillance protocols so that countries don't have to develop individual protocols for different sectors. Next slide, please. And as Tom's mentioned, the programme is very closely aligned with tripartite programmes. So there's no actual Fleming Fund surveillance system. We don't have a parallel system. It's all supporting national systems in line with the international programmes of WHO, FAO, and OIE. So in human health, that predominantly means that we support reporting to GLAS and focusing on drug-resistant infections caused by the key GLAS priority pathogens. And in practice, that actually means that much of our effort is on improving clinical diagnostic microbiology in hospital sites supported by a national reference laboratory. One of the things we found very early on is that countries were struggling with the complexity of GLAS. So we did develop, as an early output of the Fleming Fund, a roadmap under the London School of Hygiene and Tropical Medicine, so an expert group developed a sort of a stepwise approach so that countries start off with blood cultures and look at non-fastidious pathogens in blood culture so they can at least start reporting to GLAS, and then they add sample types and organisms as capacity develops. And that also includes the development of the quality component of the data. So we accept and acknowledge that in the early stages, the data is really quite dirty. But we hope that with the support of the Fleming Fund, we get to a stage where it is of acceptable quality and also is in some way representative of the country situation. It's not just AMR, it's also AMU, AMC surveillance. So in human health, we follow the WHO methodology. So most countries will be undertaking point prevalence surveys under that methodology. Next slide, please. In animal health, the approach is, in the first instance, it's active surveillance, and again, following a stepwise approach. So we've developed a sort of a beginner's poultry protocol sampling, because that's the main protein source for most countries, that focuses on E. coli and Salmonella as the important transboundary organisms, but then countries can also progress in a stepwise manner in line with the FAO guidelines on AMR surveillance in food animals. So they might progress to aquaculture sampling, they might progress to sampling, for example, for mastitis in a more passive surveillance approach in cattle. And for both human health and animal health, development of laboratory and testing capacity is alongside development of the reporting systems to make sure that data is reported and used locally and also nationally, and to the international programs that I've mentioned. Next slide, please. And the need for a stepwise approach is clear from the initial findings during development of the country grants programme. So in our scoping visits, as I've said, we review the national action plans and meet with the stakeholders. And this table shows a very basic overview of the situation at implementation, or at the start of implementation, for basic functions of an AMR governance system. So you would expect a country to have a national action plan in place, to have an AMR coordination or steering committee, to have technical working groups that implement different aspects of the National Action Plan, to be meeting regularly and undertaking activities, and for there to be government funding in place for AMRCC activities. But you can see that with a single exception, no countries, when we started the programme, and I don't think there's been much progress to date, had any government funding. They were all reliant on external donors, both for National Action Plan development and for support of the AMRCC. Now, despite that, some countries actually do have a functioning AMRCC. They will meet regularly. They have terms of reference, and the technical working groups are undertaking activities, but that is all funded externally. And in some cases, the countries are sort of meeting on an ad hoc basis, or have maybe met once, but because of the lack of funding, they haven't been able to actually progress much further on in implementation of their national action plans. Next slide, please. And that is reflected on the technical side. And I think this is just a sort of a reality check in terms of in terms of what Carmen was saying earlier about countries and the fundamental need to support basic laboratory capacity. So there's significant investment needed on the technical side. We support government sector laboratories, and they're universally underfunded and underdeveloped. We've surveyed about 156 clinical laboratories across 23 countries to date, and more than half of those require improvements in infrastructure and basic utilities, i.e. water for basic functions and reliable electricity. Although all the laboratories are clinical laboratories in human health and therefore operating at biosafety level 2, in fact, fewer than 40% actually meet the requirements for handling samples at that level. Now, there are some regional differences, and in general, we found that as you move west to east, the capacity improves. So in West Africa, there are particular challenges, and laboratories tend to be of better quality in South Asia and Southeast Asia. Next slide, please. And in terms of basic bacteriology capacity, the majority of sites really struggle to provide a reliable diagnostic service because they can't maintain reliable consumable stocks, either due to budget issues or just because of poor in-country supply chains. And that's been exacerbated, as you can imagine, over the past year. Interestingly, over 50% of the sites that we've seen don't even have a supply of horse or sheep blood. So they use expired human blood in making their blood agar, which comes with some safety issues as well as some issues in terms of how you interpret susceptibility testing that's done in that manner, for example. Actually, most sites are providing a blood culture service, but it is patchy, and over 20% of those are only performing manual cultures. And that's useful for surveillance, but it's actually unlikely to benefit patients from whom the sample was taken, which means that although the service is available, it's underutilized because doctors aren't getting their results back in a timely manner. Next slide, please. So we see similar challenges in the other sectors. Now, the majority of these sites, of these 78 sites, are animal health laboratories, and you can understand that we, the priority for the focus tends to be in human health, followed by veterinary laboratories, and then in some countries, as they got sort of capacity to do environmental sampling, that comes online. So out of these 78 sites, I think we've got 3 food safety, 1 aquaculture, and 1 environmental sampling laboratory. But across the board, most sites need improvement in infrastructure and biosafety, similar to human health, and almost all require support for basic bacteriology and reporting systems so that the data that they are able to gather gets fed back at the national level. So you can see that baseline functionality is very low, and it is an ongoing challenge. And I think that what we've seen on the ground just highlights the challenges of getting reliable data that is owned by countries, and we have the constant tension between country ownership and quality data, and getting data quickly versus getting data that the countries will stand by and acknowledge as their own. So it's an ongoing challenge. We are making some progress, so I'll hand back to Tom to give a brief overview on the achievements.
Thank you, Claire. I shan't linger long over this slide. These are a lot of process indicators, but they basically indicate that we are making progress in terms of encouraging more countries to participate in GLAS. Carmen gave you the figures in her update. We are also assisting countries in supplying data to the OIE database as well. And we're also, through our regional grants, led by ASLM and IBI, starting to map out the location and sources of historical AMU and AMR data across Africa and Asia. In addition to having over 140 fellowships approved across 20 countries. I think important that we are a novel program. I think this is the single largest aid investment in AMR surveillance, and we're determined to make sure that we're learning from our experience so that can be shared and help inform other and wider investments. We've been actively investing since, I think, 2016, and we have invested, as I saw on an earlier slide, in evaluation. It's a critical part of our fund. And for key learnings, I think it's worth illustrating here that it takes a long time to support laboratories, to build partnerships. You need trust, which also takes time, and a sustained effort as well. We have had a very careful design and engagement process. A large part of our positioning activities was securing local ministries' agreement to our investment and our plans, and building that partnership, and that stood us in good stead. It does take time. You have highlighted, I think there's a conversation earlier around the challenges with this being a very active space, and it's an increasingly active space in AMR, and coordination and alignment is absolutely crucial. We work quite closely to support coordination of a number of different programs working globally. So for the US, it'd be IDDS and MTAPS, for example, USAID programs. But it's probably worth noting that there isn't a huge amount of investment in global AMR surveillance as we speak, although we work with all active partners wherever possible. We are investing more in coordination meetings in each of the countries, and those are working well. In terms of other key learnings, really critical to demonstrate and use the data that's building to demonstrate the value of global health security, and maintain attention on AMR as a priority for international investment. This is absolutely key. And also, while we are also delivering increasing amounts of data through the investment in surveillance systems, it's really critical at the same time we build demand for that data in the policy space as well, and we start to engage through civil society also, as well as through official channels and with governments. I'll stop now for any questions, which we've allowed some space, and I'll stop sharing now, if that's okay. I think we have some questions already.
Super, thank you both. Thank you both. Yeah, there are a few questions, and then I'll probably jump in with one as well. The first question is, what is the proportion of investments into each of the sectors, human versus agriculture broadly, including animal health, I presume, and the environment?
I think that's a great question. I can't give you the precise figures off the top of my head. Claire, I mean, in terms of the number of laboratories, would that probably be a good proxy?
Yes, I think it's as you saw in the numbers of laboratories. So predominantly, well, actually, so on the National Reference Laboratory, each country will have one for human health and at least one for animal health. So that's a fairly even split. And then Sentinel sites for human health is usually 5 to 20 per country, and maybe 3 to 10. Depending on the size of the country and animal health, so it's certainly weighted more towards human health. But I think that's defensible, and it's difficult to invest heavily in countries in terms of environmental sampling or aquaculture if their clinical laboratories are of such poor quality. It just feels that that's not the right approach to take. So we do focus on the human health and then the agricultural side, and then following that, we'll prioritise according to the country needs. In the fellowship scheme, it's a pretty even split, actually, 50-50 between human health and animal health, and then depending on country needs, there may be an aquaculture surveillance fellow or an environmental AMR fellow. But yeah, it's 50-50 for human animal.
And Claire, it's probably worth noting that that's the selection of laboratories is determined by the AMRCC, so it's a nationally led decision, isn't it?
Yeah, and again, so most countries will look at the National Action Plan and see what's there. So obviously the majority of those will be human health or agricultural laboratories.
Super, thank you. Kind of related to that, because many of the procedures, once you're in the laboratory at the analytical level, are the same regardless of the sample source. Do you have any good examples where, especially in a limited resource country, rather than trying to support 2 or possibly even 3 labs, depending on the sector they best serve, that they have a single laboratory that combines all of those functions? Do you have any good examples of that, or any opinions on whether that is even a fruitful direction?
We certainly considered it in some countries, but interestingly, the countries themselves don't like that. People get very sort of very sectorial, for want of a better word. They don't particularly like the idea of a single AMR laboratory. And in terms of the types of samples coming in, you can imagine if you're working in human health, the idea of receiving, sort of poultry seeker, for example, is not terribly appealing. So people don't particularly want that. And to my mind, a national reference lab should be able to do both, but it's not something that countries want. There's certainly examples of joint training, and certainly once you get to the isolate level, we do look to combine training. We look to combine training in biosafety, biosecurity, quality management, so that that doesn't need to be sector specific at all. But yeah, I would prefer that approach, I think, but it's just not politically acceptable at the country level.
All right, thank you. Andy Strigachis has a question. Are there efforts underway to develop, track, and harmonize a set of comprehensive metrics on essentially progress?
So we have our internal sort of monitoring system which tracks progress against the London School roadmap, which I referred to earlier on. That is at very basic level. I mean, it is, what does this lab need? And then we sort of track, does it now have a blood culture system? In terms of where countries go after that, very few of them are actually at the stage where you want to start tracking out the quality metrics, etc. Okay. But as and when they do, what we will look to will be to evaluate the tools that are out there. So CDC have just launched their LARC tool. There's obviously the FAO Atlas tool, and FIND have a scorecard system that looks at the quality parameters. So we'd be looking to use one or the other, or a combination of those, I think.
Thank you. And I think we can sneak one more in here. Do you have an expected timeline for when results from the economic impact studies you have commissioned would be available?
So that relates to the kind of ODI economists, of which we have 3 or 4 at the moment, that we hope to have more in the future. They have just started over the last year, so I'll send, I can follow up with the details of when they're going to produce their analyses in due course. That shouldn't be a problem.
Okay, well, thank you. Any other questions from the committee? I don't see any that have come up. Just one question, since I've just got a couple of minutes. You really focused on some of the infrastructure challenges, which clearly are at the base of it. How about supply chain challenges you've seen in order? That's kind of a little based on personal experience. In Kenya, we have quite a bit of trouble getting consistent supply of whatever, whether it's a specific media or a Vitek cards or whatever. Any comments on that?
Yeah, I mean, I think the first thing to note is, kind of a big fund, and so we can afford to take quite a holistic approach to the way in which we're trying to tackle all of the different challenges to building a sustainable surveillance system from the outset. So one of our regional grants looks at this specifically trying to identify the specific logistical barriers that exist to getting, as you say, the right equipment, getting the right consumables, and getting a robust and sustainable supply chain set up in Africa, for example. We're not alone in looking at this. It's something that's common to lots of different programs. And I would expect that, I think that is due to report next year, that analysis.
All right. Super, thank you. Thank you, we're right on time. So thank you for being on time and giving us a little time for a few questions. That was a fantastic presentation. Our next presentation is from the Bill and Melinda Gates Foundation, who from Padmini Surakanti, who chairs their, or senior program officer for their antimicrobial resistance strategy. And I saw Padmini flash up temporarily. There, I can see her. So, all right. I think you're muted. There you go. Okay.
You go. I must apologize. I think my son has placed some sort of mustache on my face and I don't know how to get rid of it. So that's the way you're going to see me. Is it showing?
Yes.
Okay. I'll make it in presentation mode.
Yeah, it's coming up.
Okay, great. Great, so thanks everyone. Good morning, good afternoon, and good evening. I'd like to thank first the organizers for the opportunity to present on a few aspects of the Gates Foundation's AMR strategy. So first at the outset, the Foundation's interest in antimicrobial resistance directly relates to our current health strategies focused on low and middle income countries, where we are focused on supporting the development of transformative tools to reduce mortality and disease burden among the world's most vulnerable populations. At the outset, we recognize that appropriate antibiotic use has the power to save lives in these populations, and particularly in populations where the access to antibiotics still and often remains limited. However, we also recognize that the threat that AMR poses is a real one and can significantly impact the positive progress that we have seen in several indicators of neonatal and infant mortality in these populations. Combined, this reinforces to us the importance of prevention of infections, which is already a core focus of the Foundation's work. The Foundation currently supports prevention through vaccines, infection control, and the appropriate use of antibiotics. This spans beyond our focused efforts on AMR priority pathogens. As a foundation, as I mentioned, we are focused on scaling up the delivery of vaccines to maximize coverage for vaccine-preventable diseases targeted at pathogens for which there are already vaccines, such as pneumococcus, as well as even typhoid. At the same time, we're also focused on vaccine development that is targeted at pathogens that are major causes of mortality in infants and children, including next-generation vaccines for typhoid, cholera, pneumococcus, as well as new vaccines for RSV, Group B strep, Shigella, HIV, tuberculosis, and even malaria. We take the perspective that prevention of disease and related deaths is the primary outcome of interest, and that prevention of disease will also support reduction in the use of antibiotics and antibiotic-resistant disease. Prevention also takes the shape of innovations to improve infection control at healthcare facilities.
Padmini, can I interrupt just for a second to see if you can put your presentation on? It's not quite in presentation mode.
Oh, I'm sorry. I thought it was. Yeah, 1 second.
If your son has also messed with your computer, that's okay.
Is that better?
Yes, that's better.
Great, sorry about that.
Yeah, thank you.
Great. So, okay. So our AMR strategy thus continues to focus continues our focus on both prevention and the most vulnerable populations. At the foundation, much of our global health strategy is focused on, as I mentioned, the developing transformative tools to prevent and reduce mortality. And much of this is focused on improving the health of children under 5. While mortality indicators for infants and young children have declined over the last several years, there's still much work to do, particularly for newborns, where drug-resistant pathogens pose the greatest risk for poor outcomes and excess mortality, and where declines in neonatal mortality have been there, but are slower than the declines that we've seen in other age groups. Accordingly, our priority areas for AMR are to collect better data on the burden of AMR among pathogens key to our strategies in low-income countries, to better characterize AMR in vulnerable populations, and in particular newborns, to better quantify the impact of vaccines on AMR and their role as a key lever in addressing AMR, given our key focus in prevention, and to identify and de-risk promising, innovative and prevention tools and our passive immunization approaches targeting antibiotic-resistant neonatal infections. So our AMR strategy continues our focus on prevention of infections through vaccines, monoclonal antibodies, and microbiome-based approaches. This applies to our focus population on in our AMR strategy, neonates, but also applies to our already ongoing core work in pneumonia, enteric and diarrheal diseases like Shigella and rotavirus, as well as TB, HIV, and malaria. Our strategy expands this to AMR priority pathogens, and as I mentioned, places this particular focus in neonates in low and middle income countries. Our work is then characterized in 2 broad areas. The first is supportive surveillance platforms to better understand the etiologies, resistance, and burden of AMR and drug-resistant infections, particularly in neonatal sepsis, but also in other age groups. And we utilize these data to guide the second focus area, product development and investments, including through our contribution to CARB-X, which is focused solely on preventive products, in the product development of prevention of infections through vaccines, monoclonal antibodies, and microbiome-based approaches. I won't have time to discuss today, but we also have a limited portfolio that is focused on innovations in infection prevention and control at the health facility level. So I'll next briefly describe a few of our key activities to characterize the impact of vaccines on AMR, surveillance of sepsis in neonates, and an increasing focus on Klebsiella pneumoniae as a target pathogen for vaccine development. So one focus area that I mentioned is building the evidence base to support and prioritize the use of vaccines to address AMR. In 2017, we convened a consultation at the Chatham House on this issue, and a key output of the meeting was the need to better understand the potential of vaccines to impact AMR and to better prioritize vaccines that should be developed and or scaled up to make the biggest impact on both antibiotic use and antimicrobial resistance. We have 2 key partnerships that I'd like to mention today. The first is a partnership with the World Health Organization, who will soon be releasing an AMR vaccine action framework that outlines 3 goals. The first is expand use of licensed vaccines to maximize impact on AMR. The second is to develop new vaccines that contribute to the prevention and control of AMR. And the third is to expand and share knowledge of vaccine impact on AMR. Notably, this document will be released actually as an appendix to the Immunization 2030 agenda. And we hope that releasing it in this format helps to bring together both the vaccine and AMR communities on this important issue. In addition, we are working with WHO to develop a value attribution framework to prioritize vaccines against AMR. And they hope that this will serve as a platform to synthesize the best available evidence for impact of vaccines against AMR and support prioritization of decisions and investments about vaccine development. The other partnership that I'd like to highlight in our vaccines against AMR evidence-based evidence generation work is with the Center for Disease Dynamics and Economic Policy, or CDEP. They've developed an AMR and vaccines modeling consortium called ARVAC to model the vaccine impact on antibiotic consumption, AMR, and the health and economic consequences with a focus on low and middle income countries. They are focusing both on pathogens for which there is an existing vaccine, such as pneumococcus, typhoid, influenza, and rotavirus. And highlighted on the bottom right here is a paper that was published earlier this year in Nature Communications, focused on childhood vaccinations for pneumococcus and rotavirus, and the antibiotic courses that were actually avoided due to the scale-up of these vaccines. The modeling efforts are also focused on vaccines for pathogens for which vaccines do not yet exist and are currently in the development pipeline. And this includes RSV, Shigella, tuberculosis, and Klebsiella pneumonia and other gram-negative pathogens. We'll move on to a second focus of our work, which is surveillance to better understand the etiologies, outcomes, and resistance patterns of neonatal sepsis. So the neonatal sepsis surveillance platforms that we have supported in Africa and Asia have consistently in recent years indicated the important role that Klebsiella pneumoniae plays in contributing both to neonatal sepsis and related deaths in these low and middle income country settings. One partnership is with the Global Antibiotic R&D Partnership, or GARD-P, and they have recently completed a prospective multinational, multi-center observational cohort study of hospitalized infants with significant clinical sepsis. Across all these geographies from 11 countries, Klebsiella pneumoniae was, again, a leading cause of culture-confirmed sepsis. And as you might see on the right here, which shows the 28-day mortality in neonatal sepsis cases observed across countries, that Klebsiella pneumoniae compared to clinical sepsis, but also compared to other organisms with, that cause culture-confirmed sepsis, still had a higher proportion of mortality, with approximately 20% of infants succumbing to infection. These findings have been underscored in another Gates Foundation-supported multi-country surveillance platform, the Child Health and Mortality Prevention Surveillance Program, or CHAMPS, which begins with surveillance in recently deceased infants and children, and combines the use of microbiologic, clinical, and minimally invasive tissue sampling data to get at the underlying as well as immediate causes of death. Klebsiella was identified in 30% of in the causal chain of 30% of neonatal infectious deaths, and actually in the causal chain of 16% of all neonatal deaths in these 7 countries, and was shown to cause both early as well as late onset or hospital-acquired illness. So these data have now helped us to guide our prevention strategy, where we are now considering a Klebsiella pneumoniae as a potential target for a maternal vaccine given to pregnant women in their 3rd trimester, with the idea that protective antibodies generated are transferred transplacentally to the infant and can protect the neonate against Klebsiella pneumoniae infection in the early months of life. This is at a very early stage, and we're still developing our strategy on this, but recognizing that there are lipopolysaccharide and capsular antigens on Klebsiella that could form the basis of a potential target for a conjugate vaccine, our current priorities are to better characterize the serogroups of Klebsiella pneumoniae in neonatal sepsis from additional geographies in low and middle income country settings. And I should add actually to also look at how this intersects and overlaps with serogroups of Klebsiella pneumoniae infections causing infections in adults, in nosocomial infections, both in high and low income country settings, given that the potential for a vaccine that might have dual market applicability will be certainly a more attractive clinical development pathway. We're also looking at whether antibodies directed at these antigens could confer protection against the Klebsiella pneumoniae infection. And while we are establishing these proof of concept principles, we continue our support for appropriate vaccine candidates, including for Klebs, as well as other gram-negative pathogens through CARVAX. So as we continue our antimicrobial resistance work, I think our overarching theme is to be guided by a prime goal of preventing and reducing mortality from drug-resistant pathogens, particularly in these poor and vulnerable populations in low and middle income countries. We hope that these efforts actually support our overall goals of our global health strategy at the foundation. And given the overlap between the pathogens that are causing neonatal sepsis in these geographies and in these target populations, and the pathogens that are of priority globally for AMR, as listed by WHO and CDC and other bodies, that this work overall contributes to a better approach to prevention and AMR altogether. So I'll stop there, and I'm happy to take any questions. And I'll stop sharing my screen.
Yeah, thank you. Very helpful. Got a couple questions to start. One is from Michael is that he was surprised to see the microbiome featured so prominently, and would ask it, can you say a little more about evidence that how it impacts AMR infections?
Yeah, so I should clarify that actually. I think that the microbiome-based approaches are, the first is really focused more on neonatal sepsis. There was a paper published in Nature in 2017 of a clinical trial of a symbiotic, which is a combination of a probiotic and a prebiotic, given to infants at birth, which indicated a 40% reduction in neonatal sepsis, and this was conducted in India. And so the foundation was interested in these findings and is now funding a replication study and an extension of that study in Bangladesh, looking at the use of symbiotics as a potential to reduce neonatal sepsis. The other area where we have supported some investments in CARB-X, and I think this is really at an exploratory and early stage, are and microbiome-based approaches focused on decolonization and the potential that if decolonizing for our target populations, decolonizing the moms could potentially reduce sepsis in the infants. But I think there's much evidence still to be generated there.
And the question from Mary Wilson, which fits right into this, is addresses the foundation supported studies of mass administration of azithromycin, which obviously had really dramatic effects on mortality in children less than 5. But also brings with it a risk of AMR and an increase in AMR. So how do you see those studies going forward in developing?
Yeah, so I think, thanks for that question. So I think Mary's question addresses the Mordor study, of course, which showed this reduction in all-cause mortality in the under 5, particularly in the younger infant group. And particularly so driven by findings in Niger in very high infant mortality settings. So first, I think, is to say that the findings and where the findings are applicable is in a targeted setting. I don't think that the idea of mass drug administration for azithromycin would be applicable in many settings where mortality is not at the same level as what was found in Niger during that trial. What is happening now is there's a number of research studies to understand whether these findings can be not just replicated, but actually can be utilized for implementation at through the EPI program in these very high mortality burden settings. Whether the burden, the benefit, which was seen most in the youngest population, whether the benefit of azithromycin administration can be taken down into even younger group populations. And then I should mention that both in the primary Mordor study, as well as in these follow-up studies of the Mordor study, there is quite a very active area of research to address and understand what the AMR impact of these mass drug administration has been. The early findings suggest, of course, that there has been some, that there is some impact in the short term, but that in the longer term, it may or may not be continued. And I think that ongoing work both in Malawi as well as in Niger will help to shed better light on that.
Yeah, thank you. Kind of related, you talked quite a bit about the impact of vaccines, obviously, in health and long-term reducing the need for antibiotics. Yeah. I know, obviously, the foundation is also very involved with WASH studies and their impact on illness, especially in children. What evidence, or any that you've seen, relates WASH to the prevalence of AMU or AMR?
Yeah, I mean, I think it's hard to. It's very difficult to tease out specific proportions, and I think that in settings, certainly in facility settings, and I think that that's where, particularly for neonatal sepsis, we're focused the most. In facility settings where we know that in facility infection control is poor, where WASH capacity is suboptimal, that's where we are seeing greater transmission or greater acquisition of these sorts of multi-drug resistant gram-negative infections, including Klebsiella. And so I didn't go into it in my presentation, but one other arm of our strategy is really looking at where the foundation could play a role in facility-based infection prevention and control. So while there are traditional areas of hand washing and the classic pillars of infection prevention and control, which we believe very strongly are incredibly important and do include in ensuring optimal WASH practices and capacities in these facilities, our focus has been to try to understand where we can bring an innovative approach to new tools or new tools that can be applied to the facility setting to potentially reduce transmission of pathogens and reduce environmental burden of pathogens, focusing on surfaces as well as shared equipment in these areas.
And at the community level, is it just a little too tricky to actually sort that out, a cause and effect kind of?
Yeah, I think it is difficult to sort that out because in areas where there is poor WASH capacity or practices, there are often high rates of enteric and diarrheal diseases, high rates of other respiratory diseases, and even still, while access to antibiotics remains a critical problem, there is also in many settings ready access to easy access or non-prescribed access to antibiotics as well. And so it's a combination of a setting where transmission is perhaps greater because of poor WASH capacity, high rates of infection, and use of antibiotics as a way to address infections in where systems are not as strong. So I think it's a little hard to tease apart and say that focusing only on one or the other will be the key path forward.
Yeah, thank you. Do we have any other questions from the committee for Padmini while she's available? Also, if there's any other questions, at least I can see that Claire and Tom and Tim are still, at least their computer is still on. I don't know if they're still there or not. Are there any other questions from the committee?
I believe we did also have some questions for Dr. Pessoa this morning that we can revisit. And since it looks like a lot of our speakers are still available, if people have, a question they'd like multiple speakers to consider or revisit, then this would be a great time to bring that out.
Kind of looking for those.
You know, I think I have them handy. Carmen?
Yeah, I can't see the previous ones, so.
I've got them handy.
Okay.
Carmen, are you still available to maybe go through some of these questions?
Yes.
Okay. And I see that you might have handled this in the chat, but the first one was about the Eastern European countries that have surveillance but are not in GLASS. And the speaker was curious also, or another committee member was curious about Spain and Denmark, for example, not being in GLASS.
Yes, thank you very much for this question. The participation in GLASS is on voluntary basis. So although this GLASS was requested by member states, it's not an obligation that countries would participate in GLASS and share data. So the call for country enrollment is open on our website, and we do encourage, and in fact, I mentioned to you the ongoing online discussions with all countries. And I think that there has been some misunderstanding what GLASS is about. And these online technical discussions with countries, so all countries in all regions, is really clarifying many doubts. And already now we are seeing countries that do have surveillance, that do report surveillance to other networks, that are now then starting to consider enrolling in GLASS. So the bottom line is it's not an obligation, it's voluntary basis. And I think that the reason that may be because of misunderstandings that we hope to be clarifying over the coming months of online technical discussions. Thank you.
Okay, and there was also a question about the average number of sentinels per country. That might be a bit low in some African countries.
Well, these of course I can assure. I mentioned that some low-income countries are actually just starting their systems, and we do encourage to start with a few number of sites to then scale up. I don't have the precise statistics right now, the median and range, but I can provide to the committee in the coming days if you wish.
Thank you, sure. And finally, you were asked about the sampling strategy to produce AMR, AMU, or AMC data, and if that's sampling strategy is or can be representative of the population of a country.
Okay, I think that we need to understand that the level of data for AMR, AMC, and AMU are different. For AMC, it's aggregated consumption data at national level. And this has been mainly on sales, aggregated sales. So this is for the entire country. But then the data for AMR rates, it depends a lot on the distribution of surveillance sites and how representative it is for the country. So it is true that most countries do not yet have reached this data representativeness. And as part of the second phase, the second 5-year cycle for GLASS, reaching data representativeness is a main target. And we already in the revision of GLASS, we are including guidance on surveillance strategies for reaching representative data. One important strategy that we will include is the use of surveys, because right now, GLASS methodology is based on routine clinical samples. And given all breaches and the limitations I mentioned, we may not really reach representativeness only based on routine sampling clinical samples. Therefore, we may need to also complement with targeted surveys to then quickly get representative data. And this is also being discussed with countries during these months of online technical discussions. And just on the AMU, this is about prescription data, and this is more used in some a sample of hospitals, and it's more used in the sense of assisting with antibiotic stewardship strategies. So these are different kind of methods, but we try to look for representativeness of consumption data and AMR data.
Very good.
Julian, I think there was a question earlier I don't think we addressed, which was, which I think is most appropriate for Carmen, but anyone else could answer it, is whether there was any reporting of MIC data as well as just the breakpoint data.
And thank you. I can start, and the other colleagues, especially countries working in countries to large capacity, may complement. The thing is, we do encourage countries to collect the information, the quantitative measurement of the susceptibility testing, even if it is just the diameter of the inhibition zone or the MIC. So we do suggest them to collect this information, but we do not require this information to be reported to GLAS, just because already the amount of data that is required, it's been very challenging for countries. So we just prefer to encourage countries to have the data for their own purposes, but we are not making as a requirement at the global level.
Yeah, thank you. I probably just, I'm trying to see if there's other questions from our...
I think Tom had a comment on that too. Am I correct? I saw a hand up.
It's mine.
Oh, sorry, Tim. Yeah, sorry.
No, that's all right. So I did want to actually build on that, and it's really a case of reinforcing what Carmen said. MIC data is something that is incredibly useful and valuable. And while there isn't any mandatory reporting requirement at the global level, we do think that an analysis of that sort of data is entirely necessary and relevant for country level analysis. So we encourage that sort of data is captured and used. And one of the ways that we are helping to encourage that is to mobilize data that's generated for other purposes, MIC data, and having it reused and made available. An example of that is data that is captured by the pharmaceutical industry as part of their post-market surveillance activities. So it's a regulatory requirement in the United States that is done actually for antibiotic cells throughout the world. And right now, we have in a database data, MIC level data reported by Pfizer in a number of countries, and additional companies are making their data sets available, such as Shionogi, possibly GSK will follow through, Merck, and we hope others. But it's a very important question because the higher level data that ends up in GLAS quite often cannot be very actionable on the ground. And so we want to encourage and actually look at strengthening the resources for bringing together MIC level data at the country level and the appropriate tools and analysis so that it can inform not just the policy, but ideally it can be more closely linked to clinical practice. And related to that as well, we have a second project that is based in Cambodia that is actually looking at ways of taking the hospital-generated clinical microbiology data, the data that's used to inform individual clinical decisions, and have that ratchet up into not only her hospital level surveillance, but forward up into national level ultimately. And so there are a number of missing tools that actually allow this information exercise to happen, but we're looking to move forward on a number of fronts so that we can bring together that kind of information. It's made available to the right places to inform the right decisions. Over.
And Gillian, if I can complement just with one information, while we are not collecting quantitative susceptibility testing for the overall glass, in the focused component glass surveillance, specifically the enhanced gonorrhea residence and surveillance of Candida species, for these two focused components, we are collecting the quantitative data. But this, as I said, we are just at the initial phase of the implementation. So we do not have data to share at this point.
I just have a question I would put out to any of our speakers who would like to address it is, one of the real challenges in getting data is it's labor intensive of clinical microbiologists, especially in low-income countries, low and middle-income countries. They're very burdened already. It's a full-time job, and now they have to report data. Have there been any, what are the thoughts about what technological approaches could we do to take out some of that burden of reporting so that it would flow better from the primary data up into the systems such as GLASS or other systems? I know that's a bit of a challenge when you know the challenge is to have a consistent water supply. Now to add a computational technology onto it is challenging, but I just wonder what thoughts have been around that space.
So I'll jump in. And again, the projects I referred to that was centered in Cambodia, it's ACORN is the acronym for it. It's a clinically oriented research network. But they've been developing tools that are designed to actively capture clinically generated data so that it happens as a matter of course of the clinical practice. And indeed, it's all with this perspective in mind that the last thing that we need to do is create extra box checking exercise, reporting exercise, or anything that increases the bureaucracy and administrative burden on people. And that's true of any setting. And frankly, it's not simply an issue for low resource setting. But this project, we ran a pilot phase project and it was successful, and we're looking to take it to the next stage to see if it's something that can be developed to scale. And so we are looking at deploying the approach in Southeast Asia and a select number of African countries, in hospitals and slightly different circumstances, to see if the toolkit actually works in these different settings. And of course, we will also want to see if using these tools alongside the standard clinical practice actually has any impact on the outcomes for patients. So ACORN 2.0, as we're calling it now, is something that we are looking to launch early in 2021. And in fact, we're hoping, though it's not officially, the ink isn't signed on this, but we're hoping to work in partnership with Carmen and WHO with some of the practice guidelines that they've designed at WHO.
Thanks, Tim. Andy, you've got a question?
Yeah, I didn't think there would be time for this, but given the expertise represented by the speakers, I'd like to ask a question about data sharing. And for any or all of the speakers, what more should be done or could be done to promote data sharing in the context of all of these investments that are being made to help us gain a greater understanding of the burden of AMR. And with that question, I would I think the committee as well would love to hear suggestions that might continue to promote data sharing, whether it's from public sources, private sources, and so forth. Thank you very much.
Okay, perhaps I can start and the other panelists can also jump in. The issue of data sharing is, has been a continuous challenge. For instance, we have already several countries, as mentioned before, that do have surveillance data and do not yet share globally. So in the end of the day, I think there is still a need for advocacy from all stakeholders, and the WHO has been trying to advocate for data sharing, including our database is, all data, all country data is available online. You can download the Excel files with every country data, and countries, so they have to agree, when they enroll in GLASS, they have to agree that the WHO will have the data. And not yet all countries have incorporated this idea of data sharing. So I think the pledge here is for collective, not only from the WHO, but a collective continuous advocacy for transparency and the data sharing.
So I can talk a bit about what's happening under the Fleming Fund, and Andy, you're obviously aware of the challenges you faced in GRAM, and we've got regional grants looking at retrospective data collection through IVI and ASLM, and actually a big part of that has been persuading laboratories to share their data. So even though it's not great data and it's up to a decade old, there's been a lot of work around sort of sensitizing laboratories to the use of the data. We've got a specific grant looking at policy and advocacy, again with IVI, to try and come up with recommendations about how you can motivate people to share data. And I guess the other part of it is that what we observe at the country level is that although there is good quality data in many countries in the research sector, it isn't necessarily shared with the national systems, and it might not get into GLASS. And I think that's something that could be looked at, and building relationships. And I really welcome what Tim was saying about direct engagement between the Wellcome Trust and governments, that actually that would be a really useful source, I think, and potentially linking funding to the sharing of that kind of data, because a lot of it is collected not for AMR surveillance, but for vaccine surveillance, for example, and they're not really used because it's not it's not collected for the particular organism of interest. So it's just sitting there. And I think bringing that into national systems and saying, we've got a good research lab here that's got blood culture data, we're only interested in strep pneumo, why isn't the rest of that data being actively used and actively fed into national systems? And I think that would be a really, really positive development.
I can speak a little bit briefly on the foundation experience. So any of our foundation grants all have data access clauses inherently attached to them. So for all of our surveillance platform, or all of the investments we've made in surveillance platforms, data generated from these platforms are meant to be shared publicly once the investigators are able to analyze and publish their findings. And in the context of, for example, neonatal sepsis specifically, where we've had multiple platforms generating data from these different geographies, the whole is, of course, the sum is much bigger than each of these parts. And so one of our goals has really been to try to, once these data are emerging, to actually look at them in a more holistic way and support, for example, the sharing of not only the clinical data, but and the microbiology data, but even of sequencing data and supporting sequencing data, which is another element that you know, we didn't mention just now. So, for example, Klebsiella, which I've talked about as a priority pathogen for us, where we've seen come as a key pathogen in multiple geographies. We are now supporting Oxford, Institut Pasteur, and Monash to come together and develop sort of a more cohesive approach to Klebsiella sequence and related metadata, so that we have a better understanding at a global level of what these what the data show in sepsis, and starting with neonates, but then the potential to actually build out from there. And I think the potential to build out from there potentially for other key pathogens as well. So I think in some ways, you know, this is focused because we work with our grantees that way. I really want to underscore the point that Claire and I think Tim earlier made in terms of the data coming from industry in licensure and post-licensure studies, where there are really rich data there that I think are really critical and important to understanding some of the key questions that are hard to understand without having the size and breadth of the studies that they're able to do. So I know, Andy, you've been involved in trying to enable better access to those data, and we strongly support that as well.
And just to join in, I mean, Wellcome as well has very clear policies on data sharing for all the research that we support, and we're trying to actually create a culture change around data sharing, so that there is open research, and all data is made freely available, no matter who is funding it. And you know, this is something that it might seem a trivial thing to say, but actually it's non-trivial. You know, control of data is a very, very curious thing, and even in the research space, quite often there's data hoarding, and this is a cultural problem that we need to help overcome, so that data is made available, particularly when it's actionable data that can inform public health situations. So Wellcome is pushing very hard on that space, and my colleagues are trying to create a change in terms of open research and data availability. A little bit more specifically, one thing that I think we would like to see happen when we talk about surveillance is to move toward a broader surveillance agenda. I think there's significant risk here that we are going down too many narrow avenues where we are looking to overstretch any capacities to do anything by having a set of parallel surveillance systems. And so I think as funders and other actors in this space, we need to start looking very far over the horizon and thinking about what might be a simpler approach, so that we are not making unrealistic requests and expectation that there's surveillance of 1,300 different aspects of things that countries will be then needing to track targets against. It's simply not going to happen. So that's one thing I think really very important to say, is that while at the level of detail of analysis we want to do, yeah, we can talk about AMR, but as we talk about surveillance, we don't want it to sit in a very narrow niche. And lastly, just to say in terms of what we're doing, one area where we're hoping to achieve improvements for low resource setting is around how laboratory information systems work and laboratory information management. So, you know, essentially, what is the opportunity for bringing forward low-cost, flexible, interoperable LIMS systems. And this is building on a lot of work that's been done by USCDC and USAID and others. And we have a separate project looking at this in an entirely different setting in Europe. It's an IMI project focused on diagnostics, but within that is a huge, huge piece on bringing together data across several countries. And data sovereignty is an important issue here that we simply cannot overlook when we talk about these things. And there's a need to have federated structures that can support data and data access. So at risk of overcomplicating things, we do have to recognize that it's not just a case of dumping all the data in one place and putting some sort of web access and call it job done. But in fact, there will need to be distributed systems and appropriate access to those systems which recognize data sovereignty and local control and ownership over those data. Over.
Thank you. Do we have any other questions?
Yeah, it looks like Left Harris has a hand up.
Okay. I can't see that, so go ahead.
I want to take advantage of this collection of esteemed founders and ask them to tell me how they expect the post-COVID-19 situation is going to be. I see that, I can see better data sharing, but I also see a drain of resources. Any thoughts about the post-COVID or how COVID is going to affect this situation? Thank you.
I was hoping Tom would step in there. Go Carmen.
We are trying to, first of all, understand these countries, how the current COVID crisis is impacting on their ability to conduct surveillance, and also looking at opportunities to, as much as possible, not make AMR surveillance as an isolated castle, to be embedded in the surveillance activities for public health. So in terms of the impact, we are seeing that particularly the most vulnerable countries, they had to deviate the scarce resources they have for the surveillance of COVID cases. So already for this year, in the data call we made this year, we had really difficult to really receive data. Countries had difficulty to upload the data and even to do the surveillance during the year of 2020. But then what we are trying to understand, and then I think that this is targeting really the low middle-income countries, is about, okay, given the structures they have in the countries for public health surveillance, what could be the breaches and how could AMR surveillance not be an isolated island, and strengthening the capacities for public health surveillance would, of course, ultimately also strengthen the continuity, the capacity for continuing all public health activities in terms of surveillance and responding to emergencies. So this is a work that we are now assessing with our countries, what could be these bridges, already to look into future strategies for having a more holistic approach for strengthening of the public health surveillance. That said, to increase the resilience of systems to cope with crisis and at the same time continue the critical public health activities. But this assessment is being done now. We are just approaching now the countries, and the answers from this assessment and some, let's say, possible options will be discussed also during our consultation that I mentioned to be held in April 2021, if COVID permits. And just also another thing in terms of not just surveillance, but data and embedding AMR data in the overall health information systems, we are also working with partners on the development of including AMR surveillance modules under the DHIS2, which is a software that basically countries in Africa and South and Asia use a lot to monitor their health issues. As an example, tuberculosis, HIV platforms have introduced modules under this system, DHIS2, exactly to facilitate the health information management in these countries. And we are also using the same approach to really try to have one platform for health information.
So in the Fleming Fund, we've obviously encountered lots of challenges, and we flexed to some degree in some countries to try and support the COVID response. So the biosafety training, for example, obviously applicable to virology as well. So we've included virologists in that. And as Carmen says, in the long term, looking to try and strengthen general infection diagnostics and say, well, okay, we're focused on AMR surveillance, and that's really bacteriology. But once you've got a bacteriology laboratory, it's not a difficult thing to move into virology testing and actually just to put whatever instrument you need in place. And so just trying to get people out of this AMR focused approach and say, actually, this is a number of infections, and the systems that you need to do AMR surveillance and detect emerging resistance are the same types of system that you need for detecting whatever next year's outbreak or pandemic is going to be.
I'd add to that, actually points that Tim brought up earlier, both in the way that ACORN is really looking at a clinical focused approach to surveillance, that it's not one pathogen or another, that this is really bringing out the need for stronger systems and thinking about a syndrome approach or a patient-based approach, that the patient is coming in with certain symptoms or something is prompting testing, and thinking about surveillance in that way, kind of along the lines or underscoring what Carmen has said about a holistic approach. The other is, I think, the risk that there's a lot of appropriate focus on COVID right now, but there's a risk of sort of a parallel system happening. And I think we really need to think strategically about how to avoid that. Again, kind of building on something Tim said earlier, in that what are the levels of reporting and demands that are placed on countries within countries or at a global level, and how can we avoid that in this context? That I think are two really important things to bring to bear here. A little different from surveillance, and I know the question was on surveillance, but I do want to mention, just in the context of broadly AMR, that in the COVID crisis, infection control, I think, really has gotten a lot of attention, and it's a moment to actually it's gotten attention in a way that it doesn't normally. And it's a moment to really take advantage of that and see how we can leverage that to not have it be a moment of healthcare workers are at risk. And so that's why we're worried about infection control, but that infection control overall is key to delivering safe healthcare. And stoppages in essential health services were in part really due to the inability to actually have strong infection control. So I did want to add that on to sort of the larger context of COVID as well.
If I could add in, I'll try to be very brief. The COVID has obviously been a wake-up call on a number of fronts, particularly the shortcomings in our preparedness and response. A number of countries, thought they had things better in hand, and the fact is all of the plans that were in place were often not followed. And surveillance, the role of surveillance is central in preparedness and response. But we probably need to rethink how the systems are organized, and really bring together the preparedness, response, and routine observation that needs to happen, and not treat them as entirely separate spheres. Some very important evidence. Carmen mentioned that some of the more vulnerable countries suffered as a result of shifting the attention to being able to do surveillance for COVID. Well, the fact is, in the UK here and in the United States, there are a number of places where there was a complete shutdown of clinical microbiology focused on bacterial pathogens to divert attention to COVID detection. And very quite circumstantial, and not a specific pattern at a national level, but there were some serious black holes that have emerged in the richest countries in the world, where routine clinical microbiology essentially was stopped in order to turn resources toward the emergency response in the face of COVID. This is certainly got to be one of the wake-up calls that it should never happen again in that way, that we have a set of systems in place which are clearly not fit for purpose to be able to maintain routine care and routine activities, as well as respond to pandemic outbreak. And I think we have to be very clear that, of course, this is a first pandemic on this scale in any of our lifetimes, but this is the disease X that experts have been talking about. This is not a surprise. We knew that something of this nature would happen, and there were, as I said, there were plans in place that simply didn't follow through. So I think it's so critically important that attention is focused on not just the most vulnerable countries, but also the failures of those that should have been better positioned to continue with appropriate and relevant surveillance across infectious diseases.
Okay, let's see. I'm not seeing any more questions. Joey, do you see? Sometimes you got a better eye than I do.
Yeah, I've
Michael.
All right, Michael. Yes, I see you.
Since we have a few last minutes, I want to go back to the question of data sharing. So I know a couple of you said that you have data availability requirements, and I was wondering if you could either sharpen that a bit more, because there's a difference between your data must be available, your data must be dumped in Zenodo, or your data must be submitted to a structured database like SRA or ENA or GenBank. And do you already require a structured database? Is there plans to move in that direction? If it's just the data must be available, you're putting a lot of burden on people trying to aggregate it to pull.
So Michael, you're exactly right that in some cases it would be an unreasonable request to say that someone would build a database. So we do have a tiered approach to it, and it depends on the type of research, the type of data, and the general landscape around that. So in some cases we can be and are very specific and explicit about which database that the information should be provided to. But we are flexible because it's about being pragmatic. It might be that that it's just the case that the data should be made available upon request if it's very unique data sets or there isn't a place. One of the things that we are doing though alongside that is trying to identify what are the database needs and what can we do to support and facilitate the creation of databases to capture all of these data. So, well, I guess this is a public meeting, so I should be a little bit careful, but we're soon to make an announcement around the AMR register database we currently have, that we want to request for proposals for something that can be the long-term home for that kind of data. And we can envision certain data sets might be most relevant for that. But it's very clear as funders, we need to think about, what are the instruments that are available, the platforms that are available, when they do not exist, well, what is it we will want to push for? The gang in the information sciences space, was a big problem. The world is awash in data. And it's totally unrealistic to say, well, we'll just create more databases. So I mean, your challenge is right, but we're trying to move this in a way which is sensible to the circumstances and pragmatic at the end of the day.
Thank you.
Go ahead, Carmen.
Okay. So in terms of WHO, so how we go around the data sharing. Number one, I have to say that those who define the WHO policies are the countries. We, the WHO staff, we are just a secretariat, okay? So in terms of GLASS, the terms of data sharing and use of the data were discussed and agreed with countries. And so far, what has been authorized by our member states is that they would be submitting the national data aggregated at national level, and we are authorized to, once the data is publicly, and which is done. So I'm just making this clear. Before I mentioned the importance of collective advocacy. And to make it clearer now, what I mean by that is that if the countries, if the governments do not really are not convinced about the importance of data sharing and do agree with a more open data sharing, WHO and as well as other UN organizations, we will not be able to improve the policies for data sharing because these are mandated at member states. So,
okay, well, we're coming to the end of our session. I would like to ask all of the presenters, because you're just so integral to this space and this question, that if you have recommendations or specific areas you want this committee to focus on as they begin to prepare their report, we would be welcome to have your perspectives on critical areas that as we prepare our report, which is commissioned by the U.S. Congress through the National Institutes of Health, we would welcome your thoughts or recommendations to make all of the players in here work more effectively. So I think you have Jillian's contact information. Please feel free to, now or, in the coming weeks and months, provide her with information or opinions you have, because I know the committee would welcome your viewpoints, your perspectives, your recommendations as we do our work. So I think with a few minutes to spare, I want to thank each of our presenters from your various time zones for your time today. Your input has really been valuable. And to the committee members, we will see you on Friday. So gives you 48 hours to reflect on all we've heard in these first 3 days and be prepared for a vigorous discussion as we map our path forward. So thank you. Have a good day, good evening, good night.
And I'll, again, thank you, and I'll see the rest of you on Friday.
Thank you all. Bye-bye.
Bye.